This UCSD TV program is a presentation of University of California Television for educational and non-commercial use only.
We all strive to live a long, prosperous, and healthy life. With advances in health and medical sciences, this goal is ever more attainable. The Sam and Rose Stein Institute for Research on Aging is a non-profit organized research unit under the auspices of the University of California at San Diego, committed to advancing lifelong health and independence through research, education, and patient care. To better empower and improve the lives of young and old alike, the Stein Institute presents the following program.
Without further ado, I'd like to introduce our speaker tonight, and it's someone who I feel very fortunate to work with. We have Dr. Scott Irwin with us, and Dr. Irwin earned his bachelor's degree at UCLA, and then he followed with an MD, PhD at University of Illinois. He's done everything from basic bench research to working with patients. He did his residency here at UCSD in psychiatry, where he was chief resident. And as you probably saw in the announcement, he already is the recipient of many awards, grants, and peer recognition through his publications. He is the director of the psychiatry programs at the Institute for Palliative Medicine at San Diego Hospice. And what Dr. Irwin and his colleagues are doing is really ties very carefully into successful aging, in that they're trying to help people also die successfully. Something that we don't think about in those terms very often, but I've been very enlightened by Dr. Irwin and his colleagues about how important it is to pay attention to the quality of the end of our lives as well. He is also on the faculty here at UCSD now in the Department of Psychiatry, and I think he is going to really enlighten us tonight with his presentation on the opportunity for health care through palliative care. So I'd like to welcome Dr. Scott Irwin. Great. Thank you, Scott.
Thank you. Thank you, Maureen, for the wonderful introduction. And I've also received support from the Stein Institute and the Hartford Center for Aging as well. So I'm glad to be here tonight and want to talk to you about what I think is the opportunity or the future for healthcare. So in this day and age of conflicts of interest, especially as a psychiatrist, I start out by saying I have no conflicts of interest. I do have a research grant from the NIH. I do some consultant for an education institute, and I am on some committees, but none of that is related to tonight's talk. I like to start all of my talks with the mission statement of San Diego Hospice and the Institute for Palliative Medicine, and that is to prevent and relieve suffering and promote quality of life at every stage of life through patient and family care, research, education, and advocacy. And really, I think this is the mission statement of every healthcare worker. The other thing I like to do is put up this slide. This is the goddess Psyche, and she forms the root word for psychology, psychiatry, etc. It's actually fairly rare for psychiatrists to be involved in end-of-life and hospice care. But actually, she's the goddess representing beauty, soul, sleep, and death. And so in a way, I feel like I've returned to my roots as a psychiatrist by working in end-of-life care. So tonight, we're going to talk about a case, a gentleman named Carl. We're going to talk about illness, past and present. We're going to talk about domains of suffering. We're going to talk about what palliative care is. And then we're going to talk about the future of healthcare and your future, because really this is all about us. We are all consumers of healthcare. We are all going to need this. So let me tell you about Carl. Carl was an 89-year-old man who came to us at San Diego Hospice, to our inpatient care center. He had prostate cancer diagnosed 14 years prior to my meeting him. He was a vibrant man. He lived life well. He lived all over the world. He made a fortune in mining. He loved friends. He loved family. He loved food. He loved wine. He loved nature. He's one of these sort of Renaissance gentlemen that was fully engaged in life. About 6 months before I met him, he had some cancer prostate cancer that went to his spine, and he was having some pain. He had an operation to remove that cancer, and he lost his ability to walk. Ever since then, his mood has stunk. He's been tearful, and he's not had interest in any of those things I just told you that he was interested in. not even his family. He had suicidal ideation in the form of begging his family to kill him. He had looked into Final Exit, the Hemlock Society, looked online for ways to die, and the first thing he said to me was, "Doc, please give me that little red pill." And he had a goal of care, and that goal of care was no more treatments. As he was getting weaker, he would get aspiration pneumonia from swallowing his secretions that he couldn't clear, and he would become delirious. He would need antibiotics. He would get them, he would get better, and he said, "I don't want to be on this treadmill anymore. Please don't treat my pneumonias next time I get one." So we're going to come back to Carl. But I want to ask you, the audience, what adds most to the meaning, value, and quality of your life? Please feel free to speak up.
Health.
Health.
Family.
Family.
Happy. Happy life. Happiness.
Happy. A happy life.
Friendship.
Friendship.
Relationship.
Relationships.
Independence.
Independence.
Music.
Music.
Exercise.
Exercise. Anybody like food or to eat? Sex. Very important to many people, right? So what if you went to the doctor, you had a pain in your side, and like all good people, you avoided going to the doctor for months, and you went and you found out that it was cancer. It was unmistakable, you didn't need a second opinion, you had cancer, and you had 6 months to live. Now what's going to add the most to the meaning and value of your life? Family.
Being pain-free.
Being pain-free or symptom-free. What else?
Back to health.
You want to get back to health, or at least a state where you can function and do those things you said you loved. Yeah, function, maintain function.
Music.
Music, so some of the same things we heard before.
Social things.
Social things. Maybe leaving a legacy, reconnecting with family. Okay. So I want to talk to you a little bit about illness, past and present. In the past, before antibiotics, before 1940s, if you lived past the high infant mortality rate, you were likely to live into your 60s, and you were going to die suddenly of an infection or an accident. The physicians didn't really have much to offer you. They had morphine, but they would usually come to the home and be with you. And that's what they had to offer. So sudden, unexpected death. With the advent of antibiotics, and then since then, this whole revolution in medicine, we become good at prolonging the dying process. And one of these models might be the cancer model, where now you get sick and then you have a predictable decline. And this is what spawned the modern hospice movement, was how do we take care of people when they're on this decline? So this was end-of-life care. And what you're looking at is the focus of care is going up and down, and across the bottom is time. So you present with an illness, and of course at that time you want therapies to modify the illness, or even get rid of it if you can. If we don't get rid of it, it becomes a chronic illness that the symptoms need to be managed. And then in this country, we define end of life as 6 months or less. That's due to the Medicare hospice benefit. And as part of that, there's life closure, last hours of living, and also let's not forget the bereavement care that the family's going to need as well. And so this last part is really end of life or hospice care. And this is what most people think of when they think of hospices. They think of the beautiful house on the hill, grandmother is in the window, sunlight streaming down with her hands neatly folded in a rocking chair, slowly fading away, right? But hospice is really a philosophy of care. It's a care delivery method. It is not a place, although there are hospice places. So let's go to diseases and aging in 2010, and now 2011. Diseases are sometimes cured, but most often they're actually controlled. We only have cures for 5 late-stage cancers. We can cure a few more early-stage cancers. We have no cures in cardiology except for a transplant. We have no cures in pulmonology except for a transplant. and transplants come with their own issues. The rest is sophisticated palliative care or sophisticated symptom management, keeping your blood pressure down, keeping your heart beating at the right rate, keeping your cholesterol down, managing your pain, managing the swollen legs, managing the shortness of breath. Same thing in psychiatry. We have no cures in psychiatry. Sometimes we do see patients that have a complete remission and never get ill again. But for the ones that don't, there's no cures. It's all sophisticated symptom management. So the tremendous success of modern healthcare is that we've increased the life expectancy of 20 to 30 years. We can do all sorts of things now to keep people alive. But now what we've created is that more than 90% of us are going to live with chronic illness, and most of us are going to live with multiple chronic illnesses. So this is the opportunity for healthcare. How are we going to manage people with chronic illness? How are we going to manage the success of modern healthcare in increasing our life expectancy? So most of us are on a normal path of life. We have an anticipated future. And how many of us like sudden change? Nobody in this room likes sudden change? So an illness comes along and it knocks us off the illness path. It gives us an unpredictable future. It's scary. We've also created new ways that people die. So I showed you the first two curves with sudden death or the prolonged predictable death. But now this is a curve for two of the chronic diseases, chronic heart failure or COPD, pulmonary disease. And what this is people are going along, they're slowly declining, and then they have acute exacerbations. They end up in the emergency room or the ICU. They bounce back to almost to the level that they were functioning at. And then they keep this decline. And the day before they die, the best ability we have to predict how much longer they have to live is months. We've lost our ability to predict when people are going to die, to prognosticate. And then there's this curve, slow, unpredictable decline. This is what we call the dwindles, slow decrease in function, increasing dependence, probably needing to go to a nursing home. Anybody have an idea what disease process this is? This is Alzheimer's dementia, and 25% of us are going to die this way. And it's the same story. A day before someone dies, our best ability to prognosticate is months. So I ask you, what do you want your illness experience to be? All of us in this room are going to get sick. How do you want to die? Because really, this is all about us. So how many people would like door number 1? Let's make a deal. Everybody remember that show? So this is slow decline, exacerbations, ending up in the ICU, in the emergency room, bouncing back and forth. Anybody in this room want this life? Okay. Nobody's raising their hand. Number 2, 25% of us are going to die this way. Alzheimer's, slow decline. We lose our memory. We lose our ability to take care of ourselves, increasing dependence. Anybody in the room want to die this way? Okay. Nobody's saying yes. How about number 3, where you're going to get a pretty bad illness, but you'll have a slow, predictable decline? Anybody want door number 3? Okay. How about door number 4? You're going along living life to the fullest, and the next day you die. Everybody, including the camera people, are raising their hand. Okay. Unfortunately, only 10% of us get to die this way. 90% of us are going to die with doors number 1, 2, or 3. And where would you like your care where would you like to get your care? How many of you would like to die here at beautiful UCSD Hospital? Maybe ICU, maybe, Thornton's a very beautiful hospital. Anybody like to die there? Nobody's raising their hand. How about long-term care? We have some of the long-term care facilities in La Jolla on the ocean. Anybody would like to live their final days there? One person, okay. And how many of you would like to die at home, wherever you call that home? Some people are saying one and the same, right. But the point is, you want to die at home. I'm guessing you're not in the skilled nursing facility part of your facility. Okay. And would you rather die where you are living now or in the skilled side? Now, okay. So nobody wants skilled nursing facility. Okay. So here's what people want. People want to live life to the fullest. It's exactly what you've said. They want us to fix the disease if we can, but they want us to relieve suffering. 90% of people believe that it's a family responsibility to provide care to a loved one, even if it's a burden to the family. And 90% of us want to die at home. But here's what people get in our current healthcare system. 23% of us die at home. 77% of us die in institutions. And among those 77%, 53% in hospitals and 24% in nursing homes. So this is the opportunity for modern healthcare. When we get knocked off that normal path of life, the anticipated future, healthcare can help us with that desired change, including how we want to be cared for, what's most important to us, and where we want to be cared for. This is the opportunity for modern healthcare. So this is where palliative care comes in. This is the WHO definition in 2002. There's a few other definitions out there for palliative care. Palliative care is an approach which improves quality of life of patients and their families facing life-threatening illness, or any chronic illness really, through the prevention and relief of suffering by means of early identification and impeccable assessment of treatment and pain and other problems, physical, psychosocial, and spiritual. It's about matching your goals with the treatments that we provide, or matching the treatments we offer you with your goals. So what palliative care does is, one, focus on relieving suffering. It improves the effectiveness of disease-modifying therapy, so you're going to do better with your cancer therapy or better with your lung medications or your heart medications with palliative care. It also is improving the quality of living, dying, and the bereavement period after. It turns out it also prolongs life. People that get hospice and palliative medicine live longer than those that don't. And it may be combined with therapies aimed at remitting or curing illness, or it may be the total focus of care. It's not an either-or proposition. Either I'm getting curative care or I'm getting hospice care. Either I'm getting curative care or I'm getting palliative care. And we'll talk about some of that data. So here's the paradigm again, and the model that we like to espouse. Again, up and down is the focus of care, and along the bottom is time. So we present with an acute illness. Let's say it's cancer, although only 60% of our patients have cancer at San Diego Hospice and the Institute for Palliative Medicine. But you want your chemotherapy, you want your radiation therapy, whatever you need to cure that illness, to get rid of it if you can. If we can't do that, it becomes a chronic illness that you're living with, and you'll have symptoms and sequelae that need to be managed. And then again, based on the Medicare hospice benefit, the end of life is sort of when you have a prognosis of 6 months or less. It becomes an advanced disease where we want to focus on life closure, the last hours of living, and again, the bereavement care that's so important for the surviving family members. So again, that end of the spectrum is hospice care. Hospice care is enhanced palliative care that's focused at the end of life. Palliative care is all of this stuff that's involved in therapies that relieve suffering and improve quality of life, symptom management, and as you can see, it can start at diagnosis. It might be a small part of the focus of care. If you get cured, you may no longer need it. But now there's a slow transition where it can increase as you need it increased, and then if you do transition, or when you transition to hospice care, it's a smooth transition. Instead of being totally focused on cure and saying, I'm sorry, there's nothing more we can do for you, please go see our friends at hospice. How do you think that makes patients feel? Abandoned. They feel abandoned. They feel angry. They feel betrayed. But if palliative care is walking along with the curative care, we don't have that sudden transition anymore. This is palliative care. So within palliative care, or just within medicine in general, or with people in general, there's many sources of patient and family suffering. And all of these need to be the focus of our assessments and our interventions. So not only is it the disease management, how are we going to cure my cancer, or how are we going to keep it in remission? What about the physical symptoms, the nausea from the chemotherapy, the pain that I'm having from the tumors? What about the psychological issues, the depression, the anxiety, the fear? The social issues, how I see myself among my peers now. You all mentioned that social things were very important to you. How is this going to affect that, and how are we going to help you to maintain that identity? Spiritual issues, whether it involves religion or God or not, but making a broader sense, putting this into a bigger context than just yourself. The practical issues, where am I going to live? Who's going to take care of me? How am I going to pay my bills? Who's going to take care of my children? And then the end of life management. Where am I going to be when I die? Am I going to be alone? Am I going to be abandoned? Or will there be somebody there? Will I be pain-free? And then there's the loss and grief. Not only the loss and grief in the patients who are losing and grieving the things that they're losing as they lose their lives, but also their family members. And of course, this is a complex, intertwined thing, but we need to think about all of these domains of suffering. This is another way to think about that. This is Maslow's hierarchy of human needs adapted for palliative care. Maslow was an occupational psychologist who was interested in how do you get the most out of your employees? How do you get a happy employee? And so he came up with this hierarchy of needs to serve the company and the employees well. And the first thing was physiological issues. Employees need a bathroom to go to. They need to breathe clean air. It's the same thing with our patients in palliative care. They need their symptoms managed. They need their basic physiological needs met. Functional status, fluids, nutrition. So Maslow said the employees need to feel safe. They need to know that their fingers aren't going to get cut off and that they're not going to die from asbestos exposure. And same thing with our patients. Having advanced care planning, having a safe environment, promise not to be abandoned, basically a safe death. And then employees need to feel love, a sense of belonging to something bigger than themselves. And same with us. You all mentioned social issues, family, feeling part of the community. Esteem issues. So again, the psychological issues, dignity, feeling of self-control. The more you can do that for your employees, the better they're going to perform, and the same thing with our patients. And then the last is self-actualization, which many of us don't get to ever, but this is meaning, value, spiritual issues, feeling that you're something larger than yourself. On the company side, you're going to perform better if you feel like you can take ownership of the company. Same thing in your own lives. The more we feel like we're a part of something greater than ourselves, the better we feel. And the idea is if you're having physiological issues, you can't focus on your love issues or your esteem issues. And so that you need to sort of focus on the bottom rungs to move up to the top rungs. It's a little bit more complicated than that, because we all know that if you're depressed, your pain might be worse and harder to treat. And if you're in pain, you might be depressed. So it is also intertwined, but the idea is that, again, we need to look at all of these domains of suffering when we think about our patients. A lot of the things you mentioned are on here, and they're in the top 4 rungs. It's not just the physical and physiological issues. And then we need to remember who's affected. So we have families. All of us are members of families. It might be a family of one, it might be a dysfunctional family, but we're all members of families. And then if somebody gets sick, they become a patient and their identity changes. And then after they die, they leave a hole in that family, and that family needs to reform without that person. And it turns out, we know from group psychotherapy, that every time a group gets together, they form, storm, norm, and perform. And every time you make a change to a group, they go through these stages again. So somebody needs to be there for these patients and families as they transition through these things. Again, an opportunity for the future of healthcare and an opportunity for the role of palliative care and my role in palliative care as a psychiatrist. So I want to talk to you a little bit about the effectiveness of what I've been telling you about. So the effectiveness of palliative care. Turns out that it achieves far better clinical outcomes than standard care alone, and patients feel better than if they don't get it. Family members are more satisfied with the quality of care, their symptom control, the amount of respect they receive, and their access to the physicians. What about the cost? We all know we're kind of out of money in this country these days. Certainly the government, and we're hearing about changes in Medicare. So palliative care sounds great, but what's it going to cost us? It turns out that when you give palliative care, it's less expensive than standard care at the end of life. When you look at people matched by diagnosis and severity of illness, those that get palliative care, the care costs less. It's also less expensive when delivered by a specialist consultation team in combination with standard care in hospitals. So this is before hospice care, palliative care delivered to people who are not dying, do better, and it costs less than if they don't get palliative care. Again, these are for chronic illnesses. What about life expectancy with palliative care? All sorts of mythology. Well, you go to hospice, you die sooner. That's what we do at hospice. We help people to die. Well, it turns out that patients with advanced lung cancer, before they received any treatment, were randomized to standard care or getting standard care plus palliative care. And if they got palliative care and standard care, they lived longer than if they got usual care alone. In fact, it was by almost 3 months. Patients with advanced cancer randomized to standard care plus palliative care, another study, and again, 3 months, they live longer. Patients in hospice care seem to live longer. So a summary of palliative care is it's more effective than usual care alone in reducing patient and family suffering. It costs less than standard care alone, and it prolongs life as opposed to hastening death. So I want to bring you back to Carl. Again, he's our 89-year-old, almost 90-year-old gentleman who had lived with prostate cancer for some time. He was this vibrant Renaissance man that was well engaged in life. He had gotten metastases of his cancer to his spine that caused some pain. When it was tried to be surgically removed, he lost his ability to walk. He became severely depressed and wanted to die, was actively trying to hasten his own death, and said, no more, which is his right to refuse further treatments. I don't want any more medical treatment. The next time I get sick, I want you to let me die. So I met Carl, and I said to Carl, I think you're depressed, and I'd like an opportunity to try to treat that for you. You may or may not change your mind about future medical care. It may or may not work. It may make you feel worse, but we can stop right away, and we should have an answer within a day or two. How many of you have heard of antidepressants that work in a day or two? It's not what we see on TV. Well, this TV now, but no, typically 4 to 6 to 8 weeks, right? So we gave him a stimulant. We gave him Ritalin, which you all might have heard of because we give it to children a lot in this country. And I will tell you, the next day, I wouldn't say Carl wasn't depressed, but he probably no longer met criteria for a major depression or a clinical depression. He was pensive, but he was re-engaged with his family. He was talking with friends, and he was no longer wanting to hasten his death or asking us to kill him. He did not change his goal of care. He still did not want antibiotics if he got another pneumonia. 7 days later, he did get another pneumonia. He became delirious, and he died. And I feel fortunate to have been able to change his end-of-life experience for those 7 days. But it was a big learning experience for me. I had just been starting out in this. And I was in the parking lot and ran into his daughter the day he died. And she told me he had died. I didn't know that he had died. And she said, I want to thank you and your team for giving me my father back. I will no longer remember him as the man that was begging me to kill him for the last 6 months. I will always remember him as the wonderful man he always was. And that was a lesson to me that this wasn't just about changing the last few days of Carl's life. It was about changing decades of her life. And we know from research if she has a stressful experience or if she has a stressful caregiver experience, she's at higher risk for medical issues, and she's going to die earlier than the rest of us as well. So this is a huge public health issue for us to take care of not only of our very sick patients, especially at the end of life, but also their families as well. So I want to ask you, what experience do you want for your patients, for those of you that are in the healthcare profession, and your families, and your loved ones, and ultimately yourselves? Do you want time for conversations and happiness and maybe some jokes? Do you want time for hugs and to be able to be hugged? Or might you be in so much pain that people are afraid to come near you? Do you want to realize dreams? This couple got married 3 days before he died. This was in our reflection room. They had been together for a long time, but he wanted to die knowing that he had married her, and she wanted him to die knowing that they had been married. So helping people realize their dreams. We've also had military retirements, graduations, all sorts of things in our reflection room. Is the whole family going to be there? Or are you just going to be allowed one family member at a time in a very noisy and personal ICU? Are you going to have time for a last trip? She wanted a last trip with her son. I think she got 2 trips in before she died. So if we're honest about how much time people have left and what they can do, they might be able to get to do things they were putting off. Real honest conversations. Being heard, being listened to. Intimacy. The standards of practice we create and the people we train will look after us when it's our turn to receive care. Are you ready? And I really need to thank Frank. Frank is my mentor and the person who brought me into palliative care, and a large part of this talk is adapted from and borrowed from talks that he gives. Very inspirational talks, and a wonderful man. So we hope, Frank and I and the rest of people that work with us, that you find meaning, value, and quality in your life. And we want you to inspire it and empower it in others. And Gandhi said, you must be the change you want to see in the world. The way this healthcare system is going to change is from you all sitting in this audience, from you all listening to this tape. It's going to have to come from us. People are listening now. It's time for us to speak up. For those watching on the TV and anyone in this room, we have a peer-to-peer hotline. This is for healthcare professionals that have any palliative care questions. They can call this hotline at PalMed Connect at 1-877-PALMED4, which is 1-877-725-6334, or www.palmedconnect.org. And we will put you in touch with the proper expert to help you with whatever the issue. If it's pain management, depression management, delirium, if it's a pharmacy issue, a spiritual issue, call with the questions and they get routed to the right person and you get an answer. So with that, I'm ready to move on to questions. I thank you all for listening. I really appreciate being here. So the question is, how much dialogue do we have with practitioners out there, like geriatricians or family practitioners or the people that are doing mainstream medicine? And I will say that it's increasing, that this is a young field. Hospice and palliative medicine is the newest subspecialty of medicine. I believe it was 2008, maybe 2010, that it's a recognized subspecialty that's sponsored by 11 medical specialties. There are increasing number of fellows that are training every year. Here in San Diego, all of the medical students and many of the residents and fellows rotate through San Diego Hospice and palliative care, on the palliative care service, through our Institute for Palliative Medicine. And about 30% of those people end up practicing here. So we find in San Diego that hospice, people that need hospice, 60% of those people in San Diego get hospice, whereas the average in the country is 30%. And we like to think it's because of education. Other strategies are setting up consult services. So we have consult services in 4 of the hospitals in town. And by being there, that we get to walk with these other physicians as colleagues and work together. And they're seeing what we can do and how we can help and getting more and more on board with what we do. So largely our work is on the hospice side. So for hospice care, it's basically when you believe that somebody would have 6 months or less to live is when hospice can get involved. That's dictated by the Medicare hospice benefit. What I like to say is if you think someone has a year or less, it's time to at least get an informational visit and see what can be done. Because sometimes it's functional based, and those are just guidelines, they're not criteria. On the palliative care side, I would say as soon as it's a chronic illness with chronic symptoms that need to be managed, and people are on a trajectory that is moving towards end of life, that it could be right away. Cancer, I think, especially when you know you have an incurable cancer, even if it's early stage, why not get involved right away? Again, the focus of the involvement of palliative care might be minimal at that point, but then they can walk with the patient as they progress through the stages. So I think it's never too early to ask the question. And we can always say, right now you don't need us, or right now you need us a little bit, and then you need us more in the future. Yeah, so the question is, does increased activity or even physical activity hasten your death? Is that the question? Okay, yeah, so people that have sudden deaths, hospice is usually not involved with a sudden death because it was an unexpected death. Right, so again, hospice and palliative care is focused on people with chronic illnesses. So heart disease, lung disease, kidney disease, liver disease, did I say heart disease, cancer, those kind of things. I would say what we're really about is helping people live the way they want to live. And so if those people enjoyed being busy and living busy and then died suddenly, everyone in this room said that's the way they'd want to go. I'm not sure how much we would have to add, but if they had other things along the way that they needed help to live that way, that's where we would get involved. Yeah, so the question is, are there any private insurance companies that will pay for hospice care? And the answer is yes. The benefits vary, and you have to look at the individual benefits for the insurance companies. But in general, most people getting hospice care in this country are over 65 and have Medicare. And the Medicare hospice benefit seems to be the gold standard. But as you know, there are people that are younger than that do get cancer or other illnesses. And their insurances will cover it to some extent. Medi-Cal will cover it to some extent. We at San Diego Hospice and the Institute for Palliative Medicine also provide charity care, so it doesn't really matter what your funding source is. We'll provide the care. Not all hospices are able to do that. So the comment was about our art collection at San Diego Hospice and the Institute for Palliative Medicine. And it is local artists who hang their work. It rotates every quarter. There's a wine and cheese on Sundays, and part of the proceeds go to support the hospice. It turns out that we're actually the second largest art gallery in San Diego County. And it is a nice way for people to come and get to know the campus and see what we have to offer. The thing we hear most at San Diego Hospice and the Institute for Palliative Medicine is, we didn't know this was here. And what a gem. And the view of Mission Valley, both down to the mountains and out to the ocean, is quite exquisite. And actually, that's looking at the back of our building, basically from the ocean through Mission Valley. That's the back side of our building. So as part of palliative care, advanced care planning, absolutely. The sooner the better, and the better we prognosticate so that you can do that, the better. But having advanced care planning so we know what you want, we know how you want to be cared for, is very important, and making sure that it's in a place that people know about it is very important. So for the patients that don't have that, we help facilitate that if they want that. I would say to this audience, though, that it needs to be updated, and it doesn't cover every situation. So the more that if you designate someone to make decisions for you when you can't, the more they know about, in general, what your philosophy is and what your wishes are, the better it can guide their decisions for you if need be. So extremely important. Not a lot of us do advanced care planning, but more and more do so. And so that's something we can help with. That's something, if you don't need hospice and palliative care right now, you can do with your primary care physician. And then we would certainly, if we got involved, help update that and make sure that it was sufficient. I believe I can name them. So San Diego Hospice Institute for Palliative Medicine is intimately involved with the Doris Howell Palliative Care Service at the UCSD Moores Cancer Center. We also now are intimately involved with the palliative care service at UCSD's Hillcrest Medical Center. We run the palliative care service at Scripps Mercy and at Scripps Chula Vista hospitals as well. So the question is, the facility has a limited number of beds, so do you need to be in the facility, or how do we take care of people that want to be at home? So today, this sounds like it's turning into a commercial for San Diego Hospice and the Institute for Palliative Medicine. It's not my intention, but we're taking care of over 1,000 patients today in San Diego County. We are the largest and oldest non-for-profit hospice in the county. And most of those people are at home, like you all said you would like to die at home. About a third of those patients are in nursing homes. And then this facility only has 24 beds. What this facility is for is if you're having pain that's too hard to manage in one of those other settings, we bring you into this facility to have your pain or other symptom managed and then hopefully get you back to where you want to be. So we provide care. Again, hospice is not a place, it's a care mechanism. And so we provide care where you are as best as we can. About, I forget the number, but I think it's about 2/3 of our patients keep their community physicians, and about 1/3 of their patients, transfer over to one of our physicians to provide palliative care. If you keep your community physician, then our palliative care doctors can help consult if those physicians want to consult or not. But what we provide in addition is nursing care, spiritual care, social work. We have over 700 volunteers. We have home health aides that help provide. We provide all the medications that are needed, any medical equipment like a hospital bed, and then we also have bereavement care for after the death for the family as well. So hospice is really an add-on to all the care that you already receive. Yeah, the question is only, she had heard only 4% of people use long-term care insurance. It sounds like it's expensive, and she's not sure if it's worth it or not, and I don't have an answer for you. I don't know the answer to that. I know that we're starting to encourage more and more people to look into that, and it seems like it could save you money. My understanding is that it will provide you care wherever that may be, so it's not just necessarily for a nursing facility. It can be put towards care at home if you need caregivers at home, et cetera, but it might pay less percentage of that. So I can't comment on your individual needs, and I'm not an insurance person, but I think it's worth thinking about. Was this helpful for you all? Interesting? Okay. Thank you very much. So with that, I guess I'll wrap up. I'd like to thank you again for having me here. And really, I think that palliative medicine is the opportunity for healthcare, the opportunity for increased quality of life, increased care outcomes, and actually costing less and having us meet your goals with the interventions that we offer you. Thanks again.